It's 9 o'clock, so I'm going to start recording the lecture, and I'll let the rest, we're not missing too many, I'll let the rest of them in as they come. Okay, so the other day we started talking about cardiomyopathy, and we talked about dilated, and this is a disease of the heart muscle, all the cardiomyopathies, and the heart isn't working well, and as a result, you don't get pumping action, you can have impaired systolic or diastolic dysfunction. So it's really impactful for people who suffer for this. So we did dilated, now we're on to hypertrophic. So hypertrophy, if anything, means enlarged, right? So this is enlargement of the ventricle to the point that it becomes obstructive. So you can imagine the issues this causes. You have an asymmetrical septal hypertrophy. Now this is a good picture. This is in a contracted state, this one here. So see how thick this wall muscle is. The walls almost touch side to side when it contracts. Here, when it dilates, there's not an awful lot of space for it to fill. So that becomes a problem here. So this is the less common of the cardiomyopathies, but the most common genetically carried one. And it's more men than women. And this is the cause of sudden cardiac death in athletes. Now, we look at athletes, you know, you've seen those football players that are in the best physical shape you could imagine, right? They do all those drills and they run up and down and they have no fat. Well, the certain positions need the bulk, but you know, for the majority of the time, they're really in good shape. And what happens is they'll be out working and doing drills and one of them drops dead on the field. By and large, it's this hypertrophic because as they're working out every muscle in the body and the heart's a muscle. And they don't always, I mean, they get screened regularly, EKGs, you know, yearly physicals and whatnot, but it's not quite easy to pick up on an EKG until it's advanced. And I'm sure they're used to seeing, you know, well-built guys with low heart rates because their hearts are in good condition and really muscularly thick. But that's what we see. That's why we see these otherwise healthy specimens dropping dead on the field. So, main characteristics, well, there's an LVH for sure. There's a left ventricular hypertrophy that's pretty significant. There's rapid, forceful contractions. That left ventricle is thick and it's forceful when it pumps, but how much can it pump? Because there's impaired relaxation. You have muscle that's almost touching muscle. So it diminishes the ability of the heart to really relax and allow a lot of blood in. And then it's a powerful push when it does contract. And it obstructs your aortic outflow in the sense that because it's so bulky, it fills less. When it contracts, you're getting blood out, but not the normal amount of blood that we're counting on that comes from your atria into your right ventricle, out to the heart, into the left side, and so on. So you have a decreased aortic outflow. Now, this has a thickened septal wall and a ventricular wall. So that makes the pumping really, it makes it really strong, but it makes the filling really difficult. That's kind of the hallmark of this one. So what do you see? Well, they can be asymptomatic. Look at the athletes, they're asymptomatic to the point that they drop. So if they get symptomatic, what do we see in all of these things? If the concept is, if the blood is not moving forward and it's coming back, you're going to get it back into your lungs. Especially on the left side, we're talking. So we have dyspnea because you have increased congestion. You have left ventricular diastolic pressure is increased. Think about what that means. Diastole is your filling time. So in the left ventricle, when it should be relaxed and is filling, it's under pressure because all the blood that wants to come into the heart cannot because the muscle is so big and bulky, it can't relax well enough to let it all in. They get fatigued because you have decreased cardiac output. What do we talk about? You decrease the cardiac output, you can have change in mentation, you can have chest pain because you have decreased blood flowing out into the ostia inside your aortic valve. So there's less blood going out of the heart, there's less blood going into the ostia, there's less blood going to the brain. What do we see? We see angina if it's not going into your ostia. Another problem you have with hypertrophic is the muscle is so big and bulky that it actually compresses. Let me go back to this picture for a minute. As this gets thicker, it's pressing on the vasculature on the surface of the muscle. So the muscle keeps getting thicker and it's narrowing that space. It's not that your people that have MIs are having the pain and the lack of blood flow because it's clotted off. You know, those vessels are clotted off. People with hypertrophic can have angina because they're not getting enough blood through the ostia, but also those vessels on the surface, on the outside surface, are getting compressed. So if you don't have enough blood going up your aortic arch to your brain, you're going to have mental changes and even pass out. You need that. So they're fraught with dysrhythmias here. The heart gets irritable, and usually they have a BTAC V-fib kind of thing, which is what kills the athletes. So it's a sudden cardiac death, typically. Sometimes they rupture the ventricle. So the diagnostics, well, the echo is the primary one, because the echo is going to let us see the shape of this, and we can see that there's, in the pumping action, that there's abnormality, that the heart's not filling enough. It's trying to push out. It's working hard. It's a thick muscle. They can do the nuclear stress test. We have better technology if they really think you have a problem. Not that they don't do the stress test. We'll talk about them. But for this, if they really think that's your issue, they're probably going to do a cath and see what everything's doing inside. Other things, you're listening to your heart sounds. You're going to hear your S1, S2, but you'll hear other heart sounds as well. And it's very exaggerated. You can imagine if you have that thick a left ventricular wall inside and out, what it's going to sound like. So they definitely have a left ventricular hypertrophy. So what are the goals? Well, let's improve the filling. Let's improve the output, you know, and reduce the contractility. Can we do something? The heart's going to try and compensate, right? So if you're getting less blood in, you have this thick pumping action, it's going to try and just pump more and more. We don't want the heart rate going up. We need to control that. So let's control the filling, the in and out a little bit, reduce the contractility some. And in surgical procedures, we try and decrease the bulk. We try and get rid of the obstruction in there, which is a significant procedure we'll talk about in a minute. So what can they give you to achieve these goals? We're back to our beta blocker. Remember, it's going to block, it's going to dull that beta response and block that epi that's going to make you have that rapid heart rate and the diaphoresis and all that. It's going to cause your heart rate to slow down. It's going to decrease your BP a little. It helps them. We could go to a calcium channel blocker. Calcium channel interfere with the calcium in the channels in muscles. So that can help with the blood pressure. We can, if they need DIG, we give them DIG. If they need, if they're having arrhythmias, we can give them amiodarone. You can take that PO, remember the iodine in it, but you can take it PO. We give it to people IV in the hospital. Other dysrhythmic treatments, sometimes they put them on procainamide. Sometimes they have to put an internal cardiac defibrillator in. And it's kind of on the idea of a pacemaker, but it's a defibrillator. And you go into a lethal arrhythmia and it fires. And people are usually very aware that it does, and they're told that they have to come to the hospital right after it does, but it can snap somebody out of a lethal arrhythmia. But it's jarring. Sometimes they don't want it in again because they don't want to have to experience that. We can also do AV sequential pacing if there's a problem. They can go down and put a pacer in the ventricle as well as in the atria, and that helps regulate blood flow a little better. So the surgical treatments we'll talk about, they seem pretty drastic, but believe it or not, the people do well. We'll talk about a ventricular myotomy, and we'll talk about a myomectomy. So you know we're removing muscle. And it's a scary thought to think the muscle we're removing is inside the heart. So we'll talk about those. There's also a percutaneous one we do. So let's
Dr. Benetti.
Yes.
Oh, on the last slide, it was talking about how we want to reduce contractility. So why would we give them digoxin? Like, wouldn't that worsen it?
Well, it depends on what our patient's doing. If they need support for, if the BP is okay and they need support for the regulation of the contractility, they may go with DIG. They may, I've had people that are restrictives, that are hypertrophics that are on DIG. It all depends. Okay. You're going to have to assess them and see what their symptoms are like. Yeah, but that's a good question. All right, so let me go back here. So here's a word about these surgeries before we look at them. So this ventricular myotomy, what we're talking about is going into the sternum, accessing the aortic valve. Let's get rid of that thickened septal wall. Nice theory. The idea of doing it and having someone survive it seems pretty daunting, but it works. So, and then we can do this percutaneous one, and I think it's probably easier to see in pictures, but you can imagine the conduction issues we have with both of them. So let's look at this picture. Here's your ventricular myotomy. So what they're doing here is they open up the heart, and they're going to go down this septal wall and take out a chunk of this hypertrophic tissue. Now think about this. You've all had your EKG class. Down your septal wall is your conduction line, right? Your AV node down to your bundle his, your Purkinje. So this is a scary thing. Plus, as you can see in this picture, your chordae and your papillary muscles are off. See these little tabs here and these cords here for your valves? So they have to be very careful where they're cutting. So you can imagine the conduction issues they have afterwards. We're watching them like hawks. And it works for people who can survive it. They take out this chunk of tissue and they can go down this wall as well and trim some of this. But now you have a lot of scarring on the inside of that heart. And it's amazing to me, when this first came out, everyone was like, you know, and have they tried this on humans? Like, is this, and it had gone through many trials, and people, they do well in the end. Mind you, we're anticipating what the problems are. We know the conduction issues. We know the ventricle doesn't like to be annoyed. We know it doesn't like scar tissue. So, and we know the integrity of the valves have to be kept in place. So thank God it's not my job, but it's done and it works pretty well. Now here's the percutaneous one. So here they show you they're coming up the arterial side and they come down and they will find a septal artery and they go in to the terminal branch, like they try and get as close to the edge of the tissue as they can. And they inject alcohol, which typically is what kills the tissue. It gets rid of the vessel and it kills everything. So now you have dead tissue in here, then they go in and they ablate that tissue. So they're like cauterizing it. So again, you have damaged cardiac muscle, you have possible conduction issues. We're down the septal branch. You have to be very careful when not near papillary muscles and chordae, so we leave the valves where they are. And little by little, now this is a much, you know, you go in, you have to do one injection for this piece and another injection for another piece. It takes a little longer, but it's not as drastic as this one, but the outcomes is what they're seeking. Now, they have to identify this in you. They have to know you have it to be watching you and doing your echoes and all to see when your heart muscle is getting to this point that you're a good candidate for this. So this obviously isn't the guy that seems the perfectly healthy specimen on the football field that just dropped dead in Sunday's game. You know, obviously that's not who they're going to capture. So you have to be caught. You know, they have to know you have this. And while it is genetic, in a lot of cases, there's a lot of cases that aren't genetic, and a lot of people we don't know have it until it's much too far gone. So what do? Well, you're going to assess your patient. We're trying to control the symptoms here. We're trying to provide support, emotional and physical. This outside person has never heard of this. What are you talking about? Imagine someone who's healthy. I'm perfectly healthy. You know how much I run, you know how much I do this, that, and the other. How can I have this? And they're talking about going in and slicing my heart muscle. So it's very, very hard for people to grasp. And usually by the time doctors want to do something about it, it's in the throes of some episode that's happened and this person is caught completely unaware and now they're agreeing to all these procedures and things. So it's very difficult. You have to teach avoidance of stress and exertion when this patient is diagnosed and has not yet had treatment to correct this, if they can even be a candidate for it. So you have to watch that. They want to do things they've always done, they probably can't. You know, this is not overexerting and this and that. We know the heart can't compensate. So while that's a hard mental hurdle for them to get over, it's a harsh reality. You know, we really have to teach this. We want to keep them resting. We want the feet elevated to improve the return. and not have a lot of shifting, and that they're up and they're down and they're up and they're down, and the body's having to acclimate to changes in cardiac output all the time. They have to be compliant with treatment. So again, if they're taking something, they don't like the effects of it, rather than stop it, they need to talk to a physician and say, here's my problem with this drug. I don't want to take this because blah, blah, blah. And let's see what else they can do for you. The goal is we're trying to maximize everyone's quality of life. And then if they have procedure and you work in that unit, you're going to have all the post-procedure care involved with that post-op heart. So the least common is the restrictive. Just when you thought you were done the cardiomyopathies, here's another one. So this one is impaired diastolic filling and stretch, which is problematic. The systolic function seems to remain intact. But what happens? Why do we have this? Well, a lot of times we don't know why you have it. You know, you arrive in some type of difficulty, distress, we evaluate you, we find you have this, and patients will say, where does it come from? And the doctor's like, I don't know. In your case, I don't know where it's come from. Now, if you have myocardial fibrosis, they'll know that. They'll take, endomyocardial biopsy, and they'll know that. Maybe it's your rotten luck. Maybe you have other connective tissue diseases and whatnot, so they kind of steer in that direction. It could just be your hypertrophy that you have. It could just be that you have infiltration into the muscle from some other disease. Look at the amyloidosis that we talk about, right? This amyloidosis, these abnormal proteins, and they come from the bone and they deposit in tissues everywhere. And this is a problem for people who have it, skeletally and in your heart as well. So amyloidosis can be an issue. Sarcoidosis.
I'm sorry. Could we see this as other autoimmune disorders like lupus?
You can, yeah.
Okay.
You can, yeah. So that was good, thank you. But sarcoidosis is another one. This is a collection of inflammatory cells that collect different places. Typically the lung, we see it, but we can see it in heart muscle. So this is another one that why does this happen? We don't know. We're back to our poor souls who have had radiation of the chest for some reason. So you have the esophageal cancer, or you have lung cancer, or you have breast cancer. And part of your treatment is that you have radiation therapy, and you can end up with restrictive cardiomyopathy from fibrosis. So it's not enough always to deal with what they have, All right, so what do you see? Well, the patient has classic symptoms of cardiomyopathy. So they have fatigue, which right away is not making anybody, we're all fatigued, right? Dyspnea, okay, people wonder why they're short of breath. That's something that they're a little more concerned about. Exercise intolerance. You could always climb the stairs in your house. Now you climb the stairs and you're winded. That's intolerance of exercise. People know they go to their mailbox and back. Now they're short of breath when they do it. So little things like that. It doesn't have to be you usually do 2 miles on the treadmill and now you're tired at 1.5 miles. It's not always that kind of exercise intolerance. It's typically more insidious stuff. The heart cannot increase the cardiac output to meet the body's changing need. That's what it's symptomatic of. So what can you have? You can have angina, because if we're not pumping enough blood out to meet the body demand, and the patient's trying to do something, activity that we can't accommodate for, then they get less blood out of the heart, they get less blood into the ostia, you can have angina. You can get palpitations, heart gets irritable. You have orthopnea, suddenly they can't sleep lying down. Now, people, I've given you examples of this when I find someone in clinical who has the head of the bed up, or, I always ask them, did you sleep like that all night or whatever? Some people do it for GERD. They have esophageal reflux, and the doctor will tell them, put your head of the bed on stilts, put it on a couple of bricks or something, or sleep with pillows behind your head, whatever. This patient's doing it to breathe, because if they're laying flat, they can't breathe. So they're sitting up in a recliner, or they have the bed that's mechanical that raises, or they have 20 pillows behind them. So typical heart failure symptoms. They start with a little peripheral edema. They have dyspnea. They might have ascites. something like that. All of a sudden they're collecting fluid. They might have hepatomegaly, because with these heart failures, eventually a left-sided heart failure is going to reflect in right-sided symptoms. And think about what this concept is. Why is that? We always say if the left side isn't working and your left ventricle isn't pumping well enough, right, it's going to back up. Where does it come from? The lungs. Okay, so the lungs is our first category all the time. But where does it come from to get to the lungs? It comes from the right side. So if somebody has longer term or an acute onset of really bad hypertrophy, what you're going to see is it's not just going to always reflect back to the lung. You'll always get a lung symptom. You'll always get your patient short of breath and dyspneic, crackles probably, but it'll keep pushing and pushing. And where is that source? I tell you all the time, for every heartbeat that beats, there's another one right behind it. So where's that blood coming from? It's coming from the pulmonary artery, which comes from the right ventricle. So now we start seeing signs of right ventricular failure. So JVD, you can have JVD for several things. What is the concept of JVD? For you to have it, there's blood backup. Whether you learned it's a tension pneumothorax, whether it's a tamponade, whether it's a restrictive cardiomyopathy, okay? All right, so what do we do for diagnostics? Pretty nebulous. Chest x-ray. It's going to tell us what the heart's looking like, you know, give us a shadow of the heart, give us an idea maybe what kind of cardiomyopathy we might be dealing with. EKG, they're tacky at rest. The heart's not doing well, so it's going to be tacky to compensate. SVT arrhythmias for sure. You know, there's backup to the atria. That gets you your atrianoid. Then you can have blocks because the ventricle is restrictive and it's trying and it's stiff, it's not doing well. So when the muscle isn't doing well, the conduction can be off. We do cardiac echoes because then we can see wall motion. We can see how the blood is flowing, how the valves are working, how the muscle is, and they can see that it's rigid. They can do an endocardial biopsy if they're trying to find, is it sarcoidosis, is it fibrosis, is it amyloidosis, what's the etiology here? So we don't lump you as an idiopathic when in fact there's a cause. They can do CTs of the chest. That's a great test to do. They do nuclear imaging. I mean, there's a variety of things. It depends on your patient's case, what's available to the doctor, and what that particular doctor thinks will yield the best information for them. All right, what can be done? Well, for this, not so much. Not so much. We try and improve the diastolic filling, but you know, we have a restrictive heart. There's only so much you can do. We can control the symptoms maybe. You know, are you real short of breath? Do you have too much fluid on board? Do we restrict your activities so you're not changing your cardiac output needs that you can't meet? I mean, these poor people don't do well. So heart transplant, that's always a thought, but it comes down to what's the causative agent. If you have something that's going to reoccur in you, like you have an amyloidosis or something that, you know, or you wouldn't be a candidate if you're an ongoing cancer patient who's having ongoing radiation. At this point in time, that would put you off a transplant list. So who knows? If you're a candidate, they might pursue it given your age and other comorbidities. But what's your nursing care? No strenuous activity. You understand they cannot adapt for the changes in cardiac output. Compliance with meds, low sodium diet. They may want salt. They may be a salt cruncher. You know, some people are candy people like me. I have to have chocolate all the time. Some people have to have salt. It's always chips and popcorn and whatnot. They can't have it. And they'll say to you at this point, you say it's for my own quality of life that everyone's doing what they're doing. Quality of life for me is having salty food. But we know we're going to kill them if they have it, so they can't. They're probably giving this person prophylactic antibiotics because the last thing you need at this point is valve disease and whatnot from infection. Okay, so speaking of cardiac transplants, what are we talking about here? Well, we're talking about
Hey, Jane.
yes.
I'm sorry to interrupt. Are most of the cardiomyopathies insidious in onset, like they take a while to develop over time?
Yeah.
Okay, thank you.
Yeah. So, what we're talking about is transferring human hearts. And end-stage heart disease makes you an overall candidate. When they start going through the criteria, that changes. You know, some candidates just get weeded out right away. These numbers are, we're waiting on a new edition of Lewis now we're going to move to for fall. So these are probably old, but it shows you that there's more people listed than we have hearts available. And it's not an easy thing to just say, this person is in brain death and their family wants to give a heart and this person needs one, give it to them. That's not how that goes. You know, it's like transplant in anything. You have to try and get the closest match possible and the person who has the best chance of complying and surviving from it. It's no easy surgery. We still go through the United Network, the organ sharing network, and that really groups the country, in this country, by geographic regions. So in other countries, it's not like that. A lot of countries don't even do transplants, but if they do it, they don't have this kind of regulation at all. Our problem was that if you had a heart ready in Florida and you had a recipient in Colorado and they said, okay, well, let's put it in the Rubbermaid and get the person to take it on the plane to Colorado. The problem is you can get delayed. They take commercial flights. You can get delayed. You can this and that and the other thing. And the cold time, even though it's packed in ice in the Rubbermaid they're carrying, the little Playmate Rubbermaid that they use, the heart might be no good when it gets to Colorado. So we have to be practical and say geographically based areas. So maybe Florida through South Carolina over to Alabama is one geographic area. It may not be, I'm just for an example. So if one comes available, they'll try and place it in that region. If not, they'll extend to the next closest region. And they keep an active list for kidneys, livers, hearts, whatever we're transplanting all the time. So they know where the next person is. And when the person, if they die waiting, that name is instantly taken off the list, not to have any kind of, mishap about a organ heading someplace and the person is no longer there to receive it. Okay, they look at body size. We don't want to put an adult, 54-year-old adult heart in a 4-year-old child. We don't want to put a child's heart in an adult's body. So they look at body size. They look at many things. They look at ABO compatibility, how important that is, the blood typing. We look at HLA matching. This is your human leukocyte antigen, and it's a protein that's on the surface of your white blood cells, and they look at that for matching. They do PRA testing. This is your panel reactive antibody. And what this is doing is measuring the percentage of donor cells that die when exposed to recipient serum. And that gives them a really good indication of what they're up against. Now, transplant business is in fact a business because you can't stay open as a transplant facility unless you're transplanting organs. But, so do they ever take somebody whose HLA match isn't the best? Sometimes. And what they'll do is plasma freeze them and try and make up for it and whatnot. Really well-established, successful transplant centers try and stay away from that stuff because they've gotten to a point where they've established their reputation and they don't need to do that. But not that you won't see it in outlying places trying to get off the ground. So there's a long, long list and many, many people die waiting. And unfortunately, you'll see if you work in an ICU, people are put on an LVAD, then it's an LVAD and an RVAD, and they're on these ventricular assist devices until they're really turned off, because a heart isn't coming. And sometimes they're at a point where the body's so worn down that they wouldn't be a candidate for the surgery anymore. And the only way they're going to die is if they turn them off. Okay, so cardiac transplant. So here's a good picture of it. They can do it 2 different ways. This is the more common. One way they do it is biatrial. Can you imagine? They cut the atria in half and they leave, the stem on the old person, and they just put the heart in and try and connect the atria. You can imagine The arrhythmic problems are problems to begin with, but you can imagine when they've cut through your atria and tried to attach it this way. This is bicable, and this is the more common approach. And so what they do is cut the cava here, they cut the connections here, and they bring the entire heart. They don't transect the atria. They just take everything over. Now, it's a good picture for you to realize this is all anastomotic sites here and here on the aorta, on the other side. The connections vascularly are tiny, tiny, tiny anastomotic sutures that they're doing. Any of which, because this patient is hugely anticoagulated for this surgery, any one of which can seep and bleed at any time. And I've mentioned how we cut the pericardium to get in here and do the surgery. And then we're going to sew the pericardium up. So now we have the chance that if it's leaking inside at all, that it's going to collect inside this pericardium, and your patient's going to have effusion at best. They're going to have tamponade at worst. So it's dicey procedure. But in people that it takes, I won't say there aren't people that have survived them, there are people that are. But if you, like any other transplant, if you get this transplant and you don't do well with it, you are not well. You are sick to the day you die, you're sick. It's horrible to see them. You have to keep in the frame of reference that the patients you are likely to see who have transplants are the ones who don't do well, because those are the ones that have to be back in the hospital. So the ones that do well are outliving their lives. So it's hard to say, you know, even when my students would see the livers and kidneys and they would say, this is so not what, oh my God, I can't believe it. I'll never let anybody in my family have a transplant. And they got so turned off. And I would say to them, you only see the ones that aren't doing well. You have to realize how changed, how altered that demographic is. There are plenty out there who do well. And it's a choice everybody makes, you know, it's. Okay, so what are the risks? Sudden cardiac death, obviously. Many times they put the heart in there and the person's dead. I mean, it's not gonna take, they have an acute rejection and that's it, they're done. You have to be strong enough in your debilitated state, you have to be strong enough to withstand the setup for the surgery. It's like livers take probably 45 minutes to an hour to set up for, to get you in position and get you ready and get the person in the next room and the whole bit. And the person with your liver or your heart, whatever. So everything has to be set and ready, and you have to be able to tolerate that hemodynamically while they get you open and put you on bypass and the whole bit. But then you get the heart, and then you survive the surgery and they've taken you off. The other anastomotic site, let me just go back to this picture a minute, is you have been on bypass, cardiopulmonary bypass this whole time. So your body has been rerouted into another machine, and also you have anastomotic sites for that as well in your own vasculature that has kept your blood pumping. And they have to sew those vessels up as well. Okay, so what else? You can have acute rejection. God knows you can have infection. The acute rejection, the bleeding, the dysrhythmias, stuff like that is really more in the emergent, the immediate post-op, because that's what's going to kill you. You know, in the OR, everything is sterile. We hope everyone's technique in the ICU taking care of a transplant patient would have great technique also. So while you can always get infection because you will be significantly immunosuppressed, we're worried in the immediate post-op phase about your hyperacute rejections and your bleeding, your vasculopathy, the fact that they're trying to get these vessels to connect. They just connected your vessel with Joe Schmo's vessel, and on paper it seems like it's going to work okay, and maybe it's not working so good. So you have vasculopathy there, and you know that's not going to be a good transplant. That patient's not going to make it. So immunosuppressive treatment comes with its own issues. That's what increases the malignancy rate. We are altering cellular function to have you keep this organ. So many times I've told you with livers, with kidneys, with transplants, you get your organ and you might be doing okay, but you'll develop a cancer. So they need frequent endocardial biopsies. And what we're looking for is rejection. What signs of rejection are we seeing in there? That's what they're looking for. Compliance is big. Compliance is the number one thing that's going to knock you off a transplant list, is if you are not adhering to your treatment regimen, to your medications, to anything they had you do up to the point of your transplant. If they have deemed you non-compliant, you'll be off the list. They won't waste a good heart, a good liver, a good kidney on someone who's not going to comply. There's a lot of compliance after. You have to go for these biopsies, you have to take these pills all the time. It's a lot of work. Okay, so next up is our myocardial infarction. Now, the beginning of this is probably a review for a lot of you. You know, you have acute coronary syndrome in 101, not 101, 151, I think. I got to stop saying that because the numbers are going to change. The curriculum is officially through the whole round. I start the new curriculum in summer. So I got to stop calling them by the names. But Adult Health 1 goes through some of ACS. And I know you've had heart exposure in the past. So this part is our review part to get us all on the same page, okay? So when we talk about ACS, we're talking about acute coronary syndrome. And this develops when someone has had prolonged ischemia for, you know, a multitude, we'll talk about the multitude of reasons. It can be your unstable angina, which is not a good thing. This is people who wake up in the middle of the night perfectly at rest with chest pain. It's unstable. Your non-ST elevation MI, so you have had an MI, but not enough muscle damage to elevate your ST segment. Or your ST segment MI, which is significant. So systemic inflammation, you'll remember, plays a huge part in this. This is how we realize the connection between people who have poor dentition and poor dental care with an increased risk of heart disease. All right, so it all starts with coronary artery disease. That's the number one culprit. You know, people as they age, you have arteriosclerotic plaque. They might be genetic, that they just tend to have high cholesterol levels. It might be diet related. They've just had horrible diet, no exercise, whatever, but they develop arteriosclerosis. And it's going to put fat deposits through the vessels. And we just saw pictures of how tiny those vessels are on the heart that do a huge job of supplying blood to your cardiac muscle. So that fat hardens with age over time. You don't have to be 80. You could be late 30s if you have a lot of it. You could be 40s, 50s. I think my youngest MI, well, I had an MI patient that was 28, but that was drugs. That was cocaine. But I think my youngest one, aside from that, has been 38 years old. And not a profile, not a person that you would say is overweight and diabetic and all these things. Just run-of-the-mill mother, night before her daughter's first communion, had an MI. So what happens? They call this arteriosclerotic heart disease, ischemic heart disease, cardiovascular heart disease, coronary heart disease, any of it, it's all the same. You'll see multitude of terms in physician notes, and it's all the same thing. All right, so what happens? Think on your cellular level, go back to your biology and pull it forward. That's what we're doing here is reviewing, right? So blood flow gets blocked and the muscle becomes hypoxic. It needs oxygenated blood flow for the muscle to work. And it's blocked. The blood supply is blocked. So it becomes hypoxic. They don't get enough O2 in the cells, in the myocardial cells specifically here. That's going to impact the aerobic metabolism. It needs oxygen. Aerobic metabolism drives your pumping in your heart. So anaerobic takes over. With anaerobic, there's lactic acid buildup. Takes about 20 minutes of ischemia for some cell death. That's not very long. And by and large, the MI patients that come into the hospital, chest pain and unrelieved angina, whatever the condition is, they've spent an equal amount of time at home convincing themselves it's not a heart attack. So people don't often just say, what's this pain? Let me go see what it is and go to the hospital. They'll swear it was food they ate. It was, avocado always does this to them. Chinese food always gives them chest pain. It was the pepper and whatever. I mean, they'll think it was GERD that's given them, they sit home denying this for a long time, typically. So if flow is restored, which is the whole concept behind why we want to get in and do PCI and do TPA, those clot busting drugs, If flow is restored to that muscle, aerobic metabolism returns. And the body says, wow, this is great. What happened here? So we try and get to you as soon as possible so we can get that to happen. But it doesn't help if you've been, when we say to people, so how long have you felt this pain? Well, only since about 8 o'clock this morning. And you're on the evening shift. You just came on at 7 o'clock at night. Okay, this has been a while. Now, if it's going to be a really bad MI, they'd be dead by now. But it doesn't mean it's not doing damage, you know. So, all right, so here's your pathophysiology in case you need a graphic. You have deterioration of plaque that ruptures off the vessel wall. Platelet aggregation, when something foreign is flying around, what does the body do? Send the platelets, send the fibrin, send whatever, because we don't know what it is. And in helping, it thinks it's helping, it's a good idea, but it's creating now this thrombus, and now this is going around. And the chances of it getting into your pulmonary circulation, causing you a PE, or up in your brain and causing a stroke, or getting stuck in a coronary artery and giving you an MI is pretty good. So the partial occlusion, we're looking at unstable angina, possibly bad enough to be an NSTEMI, but a total occlusion is going to give you a STEMI. Okay, let me get my cursor back from my other screen. All right, here's another graphic. It's kind of an umbrella kind of graphic, pardon me, to tell you how everything breaks down. So coronary artery disease is this big deal. That's the layer on top. From that, you can have a chronic stable angina. Some people are diagnosed with coronary artery disease and they're like, okay, what do I do? And whatever the doctor tells them to do, they do. And they start a walking program and they change their diet like night and day. And they lose weight and they take their meds and they do whatever. And they have chronic stable angina for a long time. It doesn't undo your cardiac disease, but that person is thwarting it from getting worse. Now, if they have some genetic component of a high cholesterol or something, they should still do all those good things, but the genetics is probably gonna keep it going down the train. It can go then to acute coronary syndrome, which could either be your unstable anginas and your NSTEMIs, or go to your ST segment MIs that, you know, you're having a bad MI to begin with. All right, so the blood flow is stopped and coronary artery disease is the problem. And Lewis tells us the majority of cases, because there are cases, what does that mean to you? Well, if I hear that, I'm like, well, what does she mean the majority of cases? What about the other cases? So what are the other cases? People have spasms, arterial spasms, and that will do the same thing. So if your coronary artery for some reason is just, you know, spasming up, that can also give you an MI because of the same concept. It's interfering with blood flow and the muscle needs oxygen. So they classify them as the STEMI and STEMI, you know, that's either an ST elevation MI or not. Now, an acute MI occurs over time. It's a subendocardial first, and this used to be, well, they would say to the patient, you had a little MI. An MI is an MI. You have damage. You have muscle death somewhere. Now, subendocardium means it's your endocardium on the inside, right? So you had chest pain, and rather than deny it, you wanted to get to the hospital and see what it is, and they got to you in time and they say, okay, you have a subendo MI. You do have some damage. It's not transmural. It's not all the way through the heart muscle. It's on the inside wall. We estimate 4 to 6 hours to have a full thickness MI, a full thickness infarct right through the muscle. So these are the people home swearing they're not having a heart attack. It's irreversible damage when you damage heart muscle. Even your subendo, if the tissue's dead, it's dead. There's no resuscitating cardiac tissue like that. So this is why they got away from that nomenclature of saying, you had the baby MI, you had the this MI. I remember working in Boston, you know, we'd have horrible snowstorms, blizzards, and people would say, well, I didn't have an MI, I just had the baby. And they're out shoveling the walk to get the snow off the walk, and they drop dead. I mean, it was such a misnomer to say to people, a little MI, or don't worry about it. Or years ago, even they would say, don't tell your mother now. If she knows she's got a heart, you know, don't tell her she's got a heart condition. And they wouldn't tell people. So they'd go home and climb a flight of stairs, clean the garage. They felt so good all of a sudden, and we find them dead. So it's not good to not be honest. You need people to be invested stakeholders in their health, and they need to understand what's going on. So irreversible damage and MIs are life-threatening. There's no question about it. And it's usually the left ventricle is what we're talking about, because that's the workhorse. All right, so here's your graphic. It's these vessels we're talking about, these skinny little things we're talking about when people have 2, 3, 4 vessel bypasses. So here's your little blood clot that no one thinks anything of floating around. Here's what nurses don't think about when they get to a clogged IV and they don't want to have to restart it. And have you seen them? Please God, you haven't seen them, but they will take a pen and strip the line. And the patient's like, ow, like all of a sudden they felt something go through because the line had clotted off. And now guess what? They stripped the IV line and now the clot's gone. Where do you think it goes? Where do you think it goes? It's floating around the bloodstream. Now they say, well, not every little piece of clot we send out is going to collect all that and end up in the heart. We know how tiny these vessels are. This picture is enlarged how many times? Your heart's a little bigger than your fist, maybe. So how many times enlarged is this picture? And look at how tiny these vessels are. It doesn't take much for this little clot in this vein, in this artery on your, or vein on your hand to embolize and get stuck in one of these tiny little vessels. Think about what you're doing when you do things like that. So if it gets stuck here, everything below that point is ischemic. That's what the graphic is showing you. So when they do bypasses, it's these vessels they're bypassing, which is a whole nother, think of the tiny little sutures we're doing and relying on are not going to scar off and occlude again and all of that. So it's dicey. All right, so here's your STEMI. Let me do STEMI and then, because I know you know STEMI already, we've talked about it. I'm sure you've had it in another class. So we've said how it clogs the blood. The blood can't get through. You have enough damage that the tissue is dead. And the way it's reflected is when they're doing your EKG, you have an elevated ST segment. I mean, significantly elevated. So the lead position in a 12-lead EKG that they're looking at where they see the ST elevation is correlating to the site of the infarct. So they know that's how they can say it's an anterior wall, it's a posterior wall, inferior wall, lateral wall. That's how they know. If we can rapidly open the artery up, we can reduce the size of the infarct or prevent it from getting worse. But we have to have you there. We have to have space in the cath lab. I mean, all the planets have to align. You have to be one that isn't going to stay home and deny your MI. You have to come in. We have to diagnose you quick, get you up the cath lab, try and do percutaneous intervention and give you a stent or something. If you are hours out, like some people live hours from the nearest healthcare facility, then they'll be directed to give you some type of thrombolytic. If you're local to Atrium, the rigs will just bring you in to a near hospital where they can do a cath. But if you're far out someplace and they can't fly you in, they're gonna start you on thrombolytics to break down that clot. Okay, and STEMI. So you have a thrombus, but it's not completely occlusive. This is a good thing. But you can't be home telling yourself, this pain my father's having is not a heart attack, not a heart attack. Worst, it's an NSTEMI. You don't want an NSTEMI either. You don't. It's a dead muscle. You don't want it. So some blood gets by. It's not completely occluded, not enough to give you a significant ST elevation, but you'll have troponins. They'll draw some labs and they'll see you have elevated enzymes. You can have ST and T wave changes, not always. And it's not the elevation that makes you a STEMI. There's a big difference. If you're in the clinical area and you happen to be around hearts, go look at that. So they'll have a cardiac cath probably 12, 72 hours. Whenever the opening is there, they want them up to see what's going on. We don't routinely do thrombolytic therapy on these patients. They're going to wait and get a cath spot and get you in. If you're at a local hospital that's diagnosed you and they don't do caths, maybe the next morning they'll ship you out and you'll have a cath somewhere else. Okay. All right. So why don't you go take a break and I'll see you at the top of the hour. Okay, I have the recording back on. So this picture you're looking at is just to give you an idea of how these vessels go again. And we'll talk more about how they, determine, here's your left anterior descending, your right coronary artery. Your right coronary artery in about 90% of the people supplies blood to the AV node. So if you have somebody in with a right coronary infarct, you're looking for AV issues for sure. But it's just one of those graphics that you can't see the left coronary because it's behind your pulmonary artery here. Okay, so how do we classify them? Well, they're described by the area of damage. So I told you the doctors will look at the 12 lead EKG and see what leads are reflecting an ST elevation. And they're described as anterior, inferior, posterior, lateral, referring to the wall of the heart that's infarcted. Now, you can have more than one, and that's a lot worse, you can imagine. So someone who has an anterolateral has their anterior wall infarcted as well as the lateral wall. So that's like most of your ventricle, your left ventricle. They can have an anteroseptal, so that's your front part of your heart and your septal wall infarct. So what are we looking for? Damage or ischemia to valves, to papillary muscles, to conduction line up and down the septum. I mean, it's significant. So that's how you start lining up the kind of infarct your patient has with potential symptoms you might see. Here's another one that might make it a little clearer. You don't need to memorize all this or anything, but like an anterior wall infarct, it's the left anterior descending that's infarcted. So they would look at that and say, this is the wall. The inferior, the lateral, posteriors, your circumflex goes all the way around to the side. When this one is affected, it's usually lateral. So anyway, we're not cardiologists, but that just gives you a frame of reference for how they know. All right, so what else? Well, obviously the course and the prognosis depends, like always, on your pre-existing health. Are you otherwise a healthy person? Do you have this long-standing history? Do you have collateral circulation? I talked about, collateral circulation when I talked about your liver. The portal hypertension, it's so engorged and the body's trying to find any way to get rid of some of this blood and get it flowing. And if the body's healthy enough, it engages in angiogenesis because that's what tissue does. When it regrows, when you heal from something, it does that. So having collateral circulation can save your life. Usually the younger the onset of the MI, your disease is significantly worse. And it's probably genetic components and things like that that hit people at that young age. All right, so here's an idea of the collateral circulation. So here's your vessel, open and wide, healthy as can be. As you start developing plaque, your body senses a decreased flow of blood through here in picture B. So it starts connecting all these little branches to give you collateral circulation. So by the time this person is completely occluded, it's got this all around to rely on. Now, all these little vessels are not as big and as helpful as this big vessel, but it's something. So when you hear cases, like the big one several years back was David Letterman, he used to have this late night show and I guess he was pre-Jimmy Fallon-ish or pre-somebody at that 11 o'clock hour. And he was every day at the New York Sports Club, working out. Everybody used to see him. Paparazzi used to go. All the page 6 in the Daily News in New York used to get a line from him all the time. So he was always in the gym, until one day he's in the gym and he keels over and they take him to, I think it was NYU, and they work him up and they're like, hello, I think he had a 5-vessel bypass. And he was laying there, and of course he's a comedian anyway, but when he was telling about it afterwards, he kept saying, 5-vessel. Do you know what I do in that gym every day of my life? Do you know what I do? Okay. So people say, how could he have 90% occlusion in all these vessels and not be dead before now, because he had angiogenesis. He had collateral circulation. That's what dupes people into believing they're okay. Okay, so typical MI presentation. Well, there isn't really a typical presentation. It's chest pain. It's not easily relieved. Even if people who have angina are used to having periodic chest pain and they take nitro and it goes away, this is one of those that's not going away with nitro under the tongue. Sometimes you get a patient come in the ED and they say, well, I have a history of angina. If ever I have an anginal attack, I take nitro under my tongue. If it doesn't go away, I'm told to take another one 5 minutes later. And so we say, well, what happened today? I took 3, 5 minutes apart, and it didn't go away. Okay, this is unrelieved by nitro. People describe it as heavy, as burning, as aching. I've had people tell me it's drilling. It's just drilling through the chest wall. Whatever they describe it to be, it's horrific, it's impactful. And if you see someone having an MI, they look like they're having an MI. They're not just laying there saying, well, it's this little pain. And you know, that might be gallbladder that they can talk through. It might be something else, but the presentation of this person is completely different. So what's the location of the pain? Well, it's up in the chest. It's down the arms. It's substernal. It's up in the jaw. It's anywhere they say between the shoulder blades is a common one. You know, it's just anywhere they tell you in the upper chest. And what we're going to do to someone coming in complaining of general chest in the upper body is do an EKG. I had a friend of mine once when there was monosodium glutamate in Chinese food. She loved Chinese food, but every time she ate it, she had chest pain. So one time it was just killing her and it wasn't going away. And she was laying there and I called her for something. She's like, hey, I'm like, what's the matter with you? She said, I'm laying here with chest pain for like 3 hours. What in the world? She was a nurse on a busy med-surg floor. And I'm like, what are you laying there for? Go to the ED, call the ambulance. No. I said, they'll do an EKG. If it's your gallbladder, they'll tell you. And thank God she went and they did an EKG and they said, it's not your heart. And she was dying and then they checked her, it was a gallbladder. And she went and had it lapped on. But, you know, why sit home? It's crazy, you know? So they can happen anywhere. And it's this horrible pain. So when at night, people wake up at night with chest pain. It's, you know, that's not a good thing. Even if they've had a history of stable angina, the idea they're waking up at 2 o'clock in the morning and they have chest pain and diaphoresis, not good. It's likely they've got an MI. It can happen during their sleep. It can happen in any activity. And don't forget, we circle back to sex. Adults, people, human, animals, beings on the planet have sex. And so people, you will find, will be admitted to the hospital. And when they talk about the onset of symptoms, it is they were having sex and the person sometimes goes unconscious or they have horrible chest pain, can't breathe, the whole bit. So you imagine how awkward they feel coming into the hospital telling people, yes, we were having sex and he had an MI. What was that movie? Jack Nicholson. Somebody help me. Who else? Diane Keaton was in it.
Something's Gotta Give or something.
Something's Gotta Give. Thank you. Thank you. It's very similar to that, right? So sometimes it is anxiety. Sometimes it's something else altogether. But a lot of times it's heart. So when you're on a heart unit, you think nothing of it. You should think nothing of it anyway. Stuff happens, you know? And this patient needs to be able to talk about it and shouldn't be made to feel awkward about it. It's a human thing. So common in the morning. And I always say when I read that, I think it really refers to the pain is common in the morning. Could be the sex, but it's really the pain that's common in the morning. And the thing is, it's because what happens? Your cortisol surges to help you start the day. So your whole metabolism changes. So if somebody is tenuous, has some unstable angina or stable angina, and it's gotten to a point where it's not going to be stable anymore, just getting up in the morning is a frequent time they're going to have chest pain. Yeah. Remember, it's more severe than angina, not relieved by antacids. If you've worked in a ED or as a tech somewhere, they give people GI cocktails, you know, we're not sure what's wrong with you, take this, you know, they give you a little Maalox, a little Lido, a little this and that. See if they calm your stomach down to get it out of the differentials and focus and see what your problem is. Okay, so here's just some typical pain sites. Can be, this guy, see here, has on the inside of the arm, like up in the armpit. It can be anything. We don't poo-poo anything until we get some troponins and we do an EKG. And then we don't poo-poo anything. But I mean, you know, we don't say, okay, it's not an MI until we have proof. Okay, so some do not have typical presentation. And one of those groups would be women. Notoriously bad because it's not the woman's fault. It's just their symptoms are not, I'm having this horrible heart attack. Their symptoms are, I am so tired. And if people work, if they run a house, if they have a bunch of kids, they're tired. And so they don't right away think that that's hard. You know, it's a heart condition, that they sometimes have just discomfort. And so they're always taking a Tums, or they're taking a Pepcid, or they're taking something. It's just, they can be nebulous things. Someone told me yesterday, it's one of those home shows on cable. They told me, Hometown, I guess it is, the one from Mississippi. I guess one of the main characters just put out there that her mother was diagnosed with coronary artery disease, and she hadn't felt herself in months, and they couldn't put a finger on it. And she finally went to a cardiologist, and he said, you have coronary artery disease. So that was a classic example of someone who just felt blah, you know, so you just never know. Diabetics, we've touched on this before, the same risk they're at for peripheral neuropathy, that then they don't feel, you know, the damage to their feet, or they have a cut on their foot, or they don't necessarily feel their feet. So if they injure their foot, they don't know. They don't know that the cut is infected or whatever. And it's the neuropathy, right? They can do a lot of damage. They get retinopathy, so they have eyesight trouble. They get, you know, nephropathy, so they have, you know, liver, kidney trouble. So the same thing here. You can have some degree of neuropathy that they don't even feel the symptoms. And they can have what they call silent MIs. They'll go in for a physical, they'll do a routine EKG and say, my gosh, what happened here? Were you sick with something? Were you away? Did you go to a hospital? Were you aware you had a heart problem? And sometimes they don't even know. They might not have felt great for a couple of days, but they didn't think it was this. So that's how they have silent MIs. Elderly people, not just elderly people with cognitive delays, but elderly people in general are going to just have altered mental status, which is why we should assess them. It's harder in someone who has altered mental status to begin with. But many times they'll come from a nursing home and they'll say, well, you know, she just wasn't herself. She kept saying she was dizzy and her blood pressure was fine. She kept saying she was dizzy. Why? Because she's losing cardiac output. Blood is not getting up that aortic arch, getting up to the brain, and they're having dizziness. You know, they can have dyspnea. If you've damaged a wall, where is it going to back up to? It's the lung, and they have new onset dyspnea. So the women generally have a lower risk compared to men. But after menopause, what happens is LDL levels rise. They just do as part of your hormonal shifting and whatnot. And by the time 65 comes along, the risk equalizes. After that, there's more women dying than men of heart disease. So we've seen as a demographic an increased trend in coronary artery disease in African-American women. And as a demographic, you'll remember they're more prone to hypertension. So that's another consideration to think about your population of people you care for. 10 times more women die of this than breast cancer. And I don't think we see, maybe in February, you know, we were red and we do all these campaigns and whatnot, but I don't think there's the push really, because it's not specifically a woman's, thought of as a woman's disease. So the first cardiac event isn't usually drop dead, there they are, it's a heart attack. It's usually they have some other symptoms or symptoms of CAD that bring them to physicians. But it's a danger for sure. Okay, so what else? Well, the course is going to depend always on the underlying cause, on your pre-existing health. Do you have collateral circulation? It makes a big difference. So what happens cellularly? So ischemic heart cells, we know the blood is not getting to the myocardial cells, and they don't like it, right? They're in pain, they go into anaerobic metabolism and all. Ischemic cardiac cells release catecholamines. We've talked about catecholamines in your adrenal glands, right? But this is coming from ischemic cells. And it's going to release glycogen because the body's saying, wait a minute, we need help here. We're in some kind of a lactic acid state. What's happening? So they want you to get glycogen and convert it to glucose in case the body needs it. You're diaphoretic. You have vasoconstriction in the periphery. So they get clammy. Their hands are cold. Their skin is ashen in color. That's where all of that comes from, a cellular level activity. So the BP and the heart rate elevate, and then it'll drop if the cardiac output's decreased. So when the cardiac output decreases, what happens? You're not perfusing like you should. So you're going to have decreased renal perfusion. You're going to have decreased urinary output as a result. You're going to have crackles and JVD because your heart is having a problem. And it's backing up, the blood that's trying to come back is backing up into the lungs. So all of a sudden they have crackles. And before it got to the lungs, where'd it come from? It came from the other side. So you can have hepatic engorgement, you can have peripheral edema, you could have JVD if it's a bad enough MI. The heart sounds are extra. You are so focused on S1, S2, and you're listening and you're like, wow, a lot of sounds going on in here. What's happening? So we know we're patients in trouble. So nausea and vomiting. It can be a reaction to the crushing pain. Some people, it's so overwhelming and they don't even think they can draw breath. It's so bad. And it's just viscerally causing this reaction in them. Typically it's vagal stimulation also. And that vasovagal response to the cardiac injury is going to start your vagus nerve going, which you know is a long cranial nerve. And it gives you GI effects as well as heart and lung and everything else. Okay, so the temperature, we expect a low-grade temp in the first 24 hours, probably a couple of days, at least 4 or 5 days. And it's the system, your whole body is reacting to this inflammatory process. You have dead cells in your heart. So the body's mobilizing, get rid of them. What are we doing with necrotic cells in the body? So out, everything goes to get rid of them. So you have an increase in WBCs because you have cell death, right? And the myocardial cells have enzymes in them that release into the bloodstream. Those are the myocardial markers that we look for, protein markers. And by day 4, they estimate, neutrophils, macrophages start going to that necrosis to say, get it out of here. People don't do well with necrosis in the body. And so these neutrophils and these macrophages go out and they start eating up the dead tissue. So your heart wall starts getting thin at the site of necrosis. This is what puts people into trouble because they feel better, the pain is gone, they put the stent in, whatever the problem is. The outside person is not thinking, gee, my body is working to get rid of the necrosis in my heart, so I'm going to have a really thin cardiac wall. They're not thinking like that. So they're going to go home and they feel good and they do something. I had a student in class several years ago whose husband worked on trees, you know, cut down limbs and all that stuff. He was in with an MI. And she said his course went well. And, you know, after 4 days, they said, okay, you can go home. And I said, well, that's good. So what's the plan now? Was he doing his cardiac rehab? She said, well, today he's at work. I said, today he's at work? What are you talking about? Well, he felt fine. You know, he cuts trees down. He's up swinging off a tree. I said, you call him and make him get home. You call the doctor and tell them your husband went to work today. And she's looking at me. And we hadn't had the cardiac lecture then. We were only in endocrine. And I said, he's not out working on trees after an MI. What's happening here? So she got scared listening to me. So she calls the doctor and they were like, what? Does he need to be readmitted? I mean, they were having a fit. And she called her husband and said, go home. And he's like, no. She's like, go home, go home. And then she's trying to explain, my teacher said to, and he's like, huh? Like, so the doctor's office called him and said, like, what's the deal here? You know? So anyway, it's very, very thin. The body, if you're healthy enough, will try and start collateral circulation to see what it can do to help you. Now, the blood sugar can be elevated because the ischemic cardiac cells started that whole, you know, glycogenolysis, break it down, get us glucose, get all of that available to the body. So we got to watch that. because we don't want sugar out of control for this patient. We need them healing. We need to have a good level blood sugar. So we have to watch that. Sometimes they might have to go on coverage for a little while. The patient won't like it. They'll think they're diabetic and they've never been diabetic. We explain to them this is part of the process the body's doing. You can have EKG changes. With a STEMI, you're going to have the ST elevation. But you also probably learned in EKG about a pathological cue. You don't really see a Q wave per se in an EKG. I mean, you know it's there. We measure it. We know if that's the starting point of your QRS and whatnot. But a pathological cue, it dips down. It goes negatively, and it's below the isoelectric line. And so that's an indicator sometimes. And then they'll do nuclear scans maybe, and they'll see how vast the damage is, how big an area it is. It helps them plan your treatment and your cardiac rehab. So it takes about 6 weeks for scar tissue to replace necrotic tissue. So your patient is vulnerable in those 6 weeks. So we teach them that, yes, the doctor wants you to start on rehab. Rehab begins with a walking regimen. That's enough activity. That's good, regular aerobic activity for anybody. Walk. Now, they can have wall motion dysfunction. They can have altered conduction. All of that comes to play here, because if you get scarred muscle as you're going forward, they've been doing okay, suddenly they're not doing okay. They're feeling these different things. They feel pressure. They feel funny palpitations. You know, they get this feeling that comes over them. That stuff needs to be reported back to the doctor. What could be happening is you can get ventricular remodeling. This is how the heart tries to compensate. It's like a I don't know, a three-legged table. You know, it's trying to maintain its balance, but without one leg, it's going to tip. And the heart muscle's the same way. If they have ventricular remodeling that is not controlled with medication, they can have heart failure. So they tend to give them, let's look at a picture of it so you know what I'm talking about. Here's a cross-section of your heart. So here's your right side, here's your left side in picture A. This is the back of the heart over here, this yellow. Okay, so here's your transmural infarct. Here's your ST elevation MI. That's a huge infarct on your anterior wall. So all of this is dead tissue. All of this will get eaten up and replaced by scar tissue. Now look at your wall. So you can imagine this heart trying to pump is like a three-legged table. It's not the most, because this muscle is all fine and this is not. So you can have, you know, changes in your cardiac output. You can have all kinds of problems from this. So it's one of the things we have to watch for. And if you realize that it takes 6 weeks for this scar tissue to replace all that necrotic tissue, this could be further down the road. Your patient is home already. So they have to be taught to comply with the regimen, even if they feel well. They will have follow-up appointments with the doctors, but they need to adhere to what they're doing. All right, so here's a cross-section of an MI. Now, this poor soul is dead, obviously, or we wouldn't see a cross-section of his heart. So get your bearings. This is your right side over here. There's your chambers that are smaller. Here's your posterior wall back here. Here's your lateral. Here's your anterior. So this is all your left ventricle. Here's your septal. Look at these are your valves. See these little things? The cross-section cut right through some valves there. Okay, so what are we looking at? This is a subendo. This is an old MI. All this white here. And you see it was subendo. It didn't go through to the outside wall. This is old. And here, what was this? A bad bout he didn't know he had. I don't know what this was. This was old too. All of this is new infarct. All of this, all this yellow. This is why the person is dead. I mean, this is a massive MI. The valves are involved here. There's not blood supply here. We have valves involved on this side. We have septal stuff here. Look at on the septal wall, we have infarct. All of this is dead. And the necrosis, by the time this man started, it started turning black already. This is the necrosis. All of this would get like that. So this guy couldn't have survived. But all this wall would be super, super thin. And all this necrosis shrinking down. So, you know, these people have significant issues trying to maintain cardiac output. Even if he were to survive this, let's say the valves weren't involved, that's probably really had a big impact. But if it was like a bad wall like this here, even if you were to survive it, you now have this posterior wall that's just not pulling its weight. And it's really hard to maintain even cardiac output and have the body adapt. Okay, so what are the complications? There's a bunch of them. These are them, and we'll take them one at a time. Dysrhythmias, heart failure, cardiogenic shock, papillary muscle disease, ventricular aneurysm, which is not a true aneurysm because it's not a blood vessel, rupture of the walls, and pericarditis. So some of this we've talked about. It'll be familiar to you. So dysrhythmias, the most common complication, 80 to 90% of people have it. I can't think of somebody I had that didn't have it. Why wouldn't you have it? Your muscle is so annoyed. It's damaged. Your heart is like, what happened? We were fine, cohesive. We were all beating in unison. Everything was fine. What's happening over here? And any little disruption causes ectopy. Pre-hospital, it's thought that VTach and VFib are the common causes of death because someone's home probably denying they're having an MI. They get this cardiac irritability. They have frequent PVCs. There's no one there to recognize it or to treat it. You have a PVC, okay. You have a couple of PVCs, we're looking at you askew. You have multifocal PVCs and they're coming couplets and triplets. You're heading for VTach. VTach unresolved is going to give you VFib. So we start seeing cardiac irritability, we act on it. We do something to quiet the heart down. It's annoyed. So let's quiet it down before it runs into VTach, VFib, and the patient's dead. So tripped by anything that disrupts function. It can be your MI. It can be that, shame on us if you're in the hospital and your electrolytes are out of whack. That should not be on our time, that we can't keep you straight. But maybe in the setting of your fresh MI, you come to us, you're not so straight. We're working on getting your labs together because we know this can cause ectopy. We know it can cause further problems. It's not good for your brain to have shifting electrolytes. It's not good for your kidneys. It's not good for anything. So we're going to get those lights under control. We don't want Valsalva. You have to anticipate and give your patients something to poo because they're going to feel like they have to poo and they're going to want to. And at home, they probably strain to poo. They've just had an MI. There's no straining. This is a no strain zone because Valsalva, what is it doing? You know, you're increasing intrathoracic, interabdominal pressure. You know, you're decreasing heart rate. Then they relax and it's a influx of blood again. This patient cannot adapt to the changes in heart rate, changes in pressure, changes in blood flow that Valsalva will bring them. So there's no straining. The intrinsic rhythm can be altered by the fact that you infarcted your septal wall or that where you damaged your ventricle is where your Purkinje fibers are firing and now they're not firing well. And you need your Purkinjes to carry the electrical impulse all the way down the tree. Any irregular heart rate can affect the myocardium. So we see irritability, we act on it. We don't let someone sit there and see if it quiets down. No. Now you'll have people that deserve to have ectopy. People that have had 3 cardiac surgeries, they have multiple sites of scarring around the heart and whatnot. They look at them and they look to see the ectopy they're having and they'll say that's normal for them. But in the average person, if they start having increased ectopy, we act on it. We have to quiet that heart down before it starts acting up. All right, so dysrhythmias. What is after dysrhythmias? Lethal arrhythmias, usually associated with your anterior wall. MIs for sure. Cardiogenic shock, obviously, heart failure, any of that. We've talked about complete heart block in your EKG classes, that your atria and your ventricle are not talking. Your block is in your AV node. And so the classic is that your SA node is doing what it does for a living and giving you 80 beats a minute, 70 beats a minute, and your ventricle is on its own. And the only thing Purkinje fibers can do when left on their own is maybe 20 to 40 beats a minute. So you have a very slow, wide ventricular rate, you have a normal atrial rate. But your patient's going to die because they don't have good cardiac output with this kind of system where your atria are not talking to your ventricles. So that's a patient who's going to die on you. So VFib can cause sudden cardiac death right there. Once you're in VFib and your heart stands still, there's so much lactic acid buildup, we may not get through that and bring you back to anything. So everything starts with a little ectopy. You don't see all of a sudden that bed 3's monitor has a PVC and another one and not get up and do something about it. We need them to chill. Now, if we're talking about arrhythmias, we will talk about reperfusion when they give them clot busting drugs. When they give them those drugs, they get reperfusion arrhythmias, they're called. When they break through the clot and the blood starts going back to the area that was deprived, they start having all kinds of arrhythmias. And they usually have, torsade de pointe, or they have idioventricular rhythms or whatever. And they're ugly looking, but if they're watching this patient and know they're reperfusing, they may not treat them because they know it's part of the process. Not that we don't take our eye off watching, but there's a reason for it. Okay, heart failure, we've talked about this. This is classic with your cardiomyopathic patient, right? Your heart pumping is impeded. Left ventricle has failed. And that's the workhorse of the body. So dyspnea, restlessness, agitation. Remember, is the blood going out? No, we have diminished cardiac output. We're going to see it in the lungs with crackles and congestion. We're going to see it in the head with decreased or changes in consciousness because blood outflow is less. You can see it in angina. If the blood isn't getting through the ostia to feed the surface of the heart muscle, you're going to notice heart sounds. You can see JVD, heart failure. Left-sided will eventually show on the right side, eventually. Extra heart sounds, keep on top of your patient. You have to hawk them. All right, so cardiogenic shock. You've learned about shock states. You know how it's decreased tissue perfusion. And there's many reasons, you're septic and you're neuro and, many reasons for shock, hypovolemic. But this one is cardiogenic because it's the heart that's causing it. So you've had this massive MI, and now left ventricular failure is so bad, and this can be pretty sudden. You can have an anterolateral or anteroseptal, just have a huge MI, and you have really poor tissue perfusion. It requires aggressive management if we're going to keep this patient alive. The mortality and morbidity of cardiogenic shock is very, very high. So they take you right into PCI. If they can put you into percutaneous intervention and get a stent in there and open that vessel up, they're going to try. If you're at a hospital that doesn't have it, that's a different story. Your odds just kind of diminished. We give them thrombolytic therapy. If you're out 2 hours away from the nearest hospital, you have no way of getting there quicker, they're going to start you on thrombolytics if you can take them. You might not meet the criteria, if you've had surgeries and whatnot, because these clot busters are clot busters. They break up anything that resembles recently cut. So, it's a problem. We have to increase the O2 delivery and decrease the demand. The problem here is the whole body is waiting for oxygenated blood, and the heart can't pump to give it to them. So we have to increase that oxygen delivery somehow to the body, to the heart, to the brain, to the organs. We have to increase it, and we have to decrease the demand. That's the supply and demand issue here. So control the arrhythmias. We have an intra-aortic balloon pump that I'll talk about later when I do cardiogenic shock lecture. But an intra-aortic balloon pump kind of takes over the work of the left ventricle. And so that's something we can do. We can give vasoactive drugs. These are drugs, sometimes we think of vasopressors. Well, vasoactive causes activity, whether it's constriction or relaxation. And depending on what this patient presents with and what their issue is, they may need this one more than that one. So we'll put them on some kind of vasoactive drug, either to increase blood supply to the vital organs, or if they have very little pumping action, maybe we need to decrease some resistance, some systemic vascular resistance. So there's a very high mortality and morbidity with cardiogenic shock. Remember, we have to increase oxygen supply and reduce the demand, and we have to do it quick. All right, papillary muscle issues I talked about with valves. So knowing the area of your patient's infarct is important. We saw on that cross section that it involved the valves, blood supply to the valves. So if your infarct is near mitral valve supply or it affects papillary muscles, they're not working. Now they're ischemic and those muscles can't work on top of your ventricle wall not working. So if they don't work, your valves aren't working. And now we're not processing blood. We're not even attempting to process blood. So what can they do? Well, an echo would be the wonderful choice. And sometimes if we've rolled you right in the hospital, right up to the cath lab, they do an echo while they're prepping you for cath. That's great. But if you're up in a bed already someplace on a floor, even in an ICU, a cardiac ICU, there's no time to take you to echo. They kind of have to understand your history and what's going on with you at the moment and say, this is a mitral valve issue. And boom, take you up and try and fix it. Papillary muscle rupture is life-threatening. And it's harder to determine. The patient is dyspneic, but they can be anyway from the MI. They could have pulmonary edema, but they can be anyway from the MI. They have decreased cardiac output. Okay, still walking, talking like an MI, but it could be all this time that the papillary muscle has ruptured from the wall, and that's why the valve's not working. So sometimes, in spite of all the efforts, somebody still doesn't respond and die. And it's not till a post-mortem that they come back and say, you know what, they had ruptured a papillary muscle all along. How are we to know? Or, you know what, they ruptured their ventricular wall. How did we know? You know, those things you don't know. So we do everything we can to try and help them in the moment. And if they're gone and we can't figure it out, the post-mortem will tell us. So if they happen to be where we could get them up and replace a valve and repair that muscle a little bit, great. But the idea of taking you now in the condition you're in, getting you up to a free OR space, getting a cardiac team to come in and crack your chest and get in there, the time it takes is probably not optimum. All right, so left ventricular aneurysm. So I alluded to this before. This is called a ventricular aneurysm. It's not a vessel. It's not an artery. It's not an aneurysm, a true aneurysm. But they call it this because we've talked about the damaged wall. You have an infarcted anterior wall, and neutrophils and macrophages, everything comes and eats away the necrosis. And now it's very, very thin. Well, it doesn't have a lot of support. It's scar tissue. So it tends to bulge out. So they call it an aneurysm. It's really kind of a misnomer, but that's what it is. So it can be the week after, it can be a couple of months down the road that this is developing, that it's just getting weaker and sloppier and it's just lost its tone and it's kind of bulging out. The problem is, if the patient isn't coagued well, clots can catch in there. It also affects your cardiac output because that muscle is not contracting well if it's got this big floppy section of muscle that hasn't healed well. So the biggest risk is rupture of that ventricular wall. And that's usually what kills these poor souls that have this. So a septal ventricular rupture, not a good thing. Septal wall is usually an acute MI that does it. And we hear this loud murmur. I mean, something is just unusual about this patient. They'll usually, in a fresh MI like this with these symptoms, they'll try and get an echo done and see what's going on. They could be already in cardiogenic shock. They could be in heart failure from the get-go, and it's just making you think there's something bigger than the size of their infarct causing all this. In a person who might have been otherwise healthy, you know, something is pulling you a little more to say it's more than just the obvious. And that ventricular wall will rupture. And it's due to the eating up of the necrotic tissue. And it's a bad thing. I've had it happen to patients. We're coding them. Oh, they don't respond to anything. And we keep going and going and going. And then when they finally call it, a couple of days later, they'll come back and say, that person ruptured that ventricular wall. And we were thinking we were making a difference, you know. And you have no way of knowing. You have to do it anyway, but it's hard. All right, so pericarditis, we've talked about this, right? This is the same pericarditis from the pericarditis lecture. So it's the inflammation, it's common a couple of days after an MI. It's just from the inflammatory process of the MI that's very different than somebody who has effusion from infection or metastasis or something like that. The chest pain the patient feels is worsened by breathing. So they'll always come in telling you it's a breathing issue. Remember, you have to have them hold their breath and then see if they still feel the pain. Sitting them up and forward gives them relief. That's another thing that you go by. If you get a chance to hear a friction rub, listen to it, because it's really a very grating sound. Think of two pieces of sandpaper. They can have EKG changes with this, but remember we do the troponins too. So even if we see some funky things on the EKG, the troponins won't be high in pericarditis. Okay, and they can give you Advil, aspirin, Tylenol, whatever the doctor orders really. Okay, Dressler syndrome, this is pericarditis also, but this is it's more autoimmune. It's weeks out, sometimes a month or two out from having the MI. We also see it after cardiac surgeries in people with autoimmune diseases. We've had to cut the pericardium, remember, so we sew it back up. That inflammation is enough to trip a response like this. So pericardial pain, they can have fever, malaise. They're more apt to get steroids for this one because they will believe at this point that it's autoimmune, but they're going to check the SED rates and the C-reactive proteins and all. Okay, that's your Dresslers. So back to your ACS diagnostic. So what do we do? An EKG is what we're going to do. Let's see what it is. Does the EKG tell the doctor that it's unstable angina, that it's an NSTEMI, a STEMI? I don't know. Unstable angina can be tough to control because it's so unstable. An NSTEMI is your partial blockage. A STEMI is your complete blockage. 12-lead EKGs are done serially from admission. And the thing about it is they will do serial EKGs all the way in. You will see an evolving MI. You'll see an MI. If they treat them with PCI or clot busters, you see it evolve. And you see it come back. And it's unbelievable to watch it. Now, if they clot again, if they reinfarct, you see the whole process over again. So, but it's interesting. It's an interesting process. We do them serially, constantly. All right, so the diagnostics. I've talked about these protein markers. So this is what's released into the blood, these troponins, when the heart muscle dies. And, it shows you in medicine, the more we know, the better we do. And so we have to keep going with research and things because we glean a lot from it. Historically speaking, in my practice time, we used to go by myoglobin. And that's the one on the bottom now. It released in 2 hours, it peaked in 3 to 15, and that was it. So think about your patient who's sitting home denying they're having a heart attack. They might not even be at the hospital by 12 hours. So they come in, how much of a myoglobin increase are we picking up on them? So it wasn't great. It wasn't great. Then they came along with CKMBs. Well, CKMBs were always there, but they discovered the usage for them. This is creatine kinase myocardial bands. So this was specific to myocardial tissue, and it rose in 6 hours, and it peaked in like 12 to 18, and it stayed for 24, 36 hours. So we had a better chance of catching your patient who was positive for an MI. But now we look at troponins. And troponins spike in 4 to 6, and they're cardiac specific. The ones we're looking at are cardiac specific troponins. They peak in 24, but they level out 10 to 14 days. So we have a much better view of maybe the diabetic who's been home nursing this feeling of malaise when the whole time they've been infarcting, or the person who's been popping Tums and taking nitros in between and doing whatever, thinking it's their stable angina that now is not so stable. So we get a much better indicator of what's going on with the patient. So here's our graph to show you the difference. This, your myoglobin here, and myoglobin can be affected by other things, God knows, but this is all we had. So you missed that window, you missed it. We had no lab proof you had an MI. then here's our CKMBs, which are still used in some hospitals. I know every time I travel around, going to conferences, people say, that's what we rely on is the CKMB. But most places will use the troponin. And here we have a much higher spike for a much longer period of time. So it's a better test. Okay, so coronary angiography. Well, we do this. We do it for STEMIs. We're going to evaluate the extent of your disease. We're going to go up there and go up into the artery and go in and put dye in and see what's going on with the heart. We can do a stent while we're in there, but we're also assessing everything else in the heart, and it's bird's eye view. Now, it's not that they're not without complications. We talked with Tamponade that they could be doing one of these. Those vessels are so tiny that they're putting these stents in. They could perforate that. And it's dripping, dripping, dripping blood, which then hours later will equate to you coming on your shift and your patient having a pericardial friction rub and ending up with having an effusion that could extend to a tamponade. You know, they're not without risk, we know that, but it's really evolved to a great practice that they can get in there quick and mitigate the damage done with MIs. So it's important, you know, if the patient's a candidate, they try and go for it. So optimum is within 90 minutes of chest pain. Well, considering most people are still home denying they have it, they're not usually within 90 minutes. But if somebody has a known heart condition, if the doctors have said to them already, you have coronary heart disease, we have to be careful of this, whatever, they may respond a little quicker. So anyway, they can do it after unstable angina and STEMIs. Usually not immediate. They'll wait till the patient is over whatever episode they had and then feed them in. It's not as emergent as your STEMI that we need to get in there and open that vessel so you don't kill another wall of your heart. So it will confirm Prinzmetal's angina. This is spasms, coronary artery spasms, and it's typically seen in people that have horrible angina at rest. So it's helpful with that. They do use it for that one in particular. So other testing, what can we do? Well, we can do an echo that we've talked about. Echo's always good. It tells us a lot about the chambers and how the blood is flowing. That's a good view after you've had an MI. Let's see how everything's working, your motion, your walls. We can also do stress testing. So let's say they still use it now, and it definitely has its place. Let's say we have a patient who's in the hospital who's not able to get up and run on the treadmill. We can put you on the treadmill, and you don't have to run. They speed your walking. They just try and get your heart rate up is what they try and do. So even if the patient can walk fast, but they can't run per se, you know, they keep a blood pressure cuff on you, you're being monitored, and the whole time they're increasing duress on your heart and watching on a screen to see what that looks like on an EKG and what it looks like vital sign-wise. So it gives them a baseline. Now, if your patient can't exercise, we can still get the same kind of information with this, these medications that we use. So you may have seen, they use the adenosine MyoView a lot at Maine, so you may have heard people going for that one. But they can go for a dobutamine stress test, they can go for persantine, or they can go for adenosine. And what do these do? They first put a tracer in the blood, you know, TN99 or something. They put something in there that's going to be radioactive enough to let the blood system light up. And then they put the drug in. Now, the action of these drugs are different. Let's take dobutamine. Dobutamine is a beta-1 selective. It's inotrope, it's a positive inotrope. It is going to increase the heart rate, but it decreases systemic vascular resistance. What does that mean to you? It's decreasing the pressure the heart has to get over to pump out into the system. So maybe you're a patient that needs that dilation out there, but you need an increased heart rate. What it's doing for us here is it's mimicking an elevated heart rate. It's not making a negative test come out by adding more stress on the heart, by the heart having to overcome this great systemic vascular resistance. So that's decreased, and the dobutamine is increasing your heart rate. So it makes your heart act like you're exercising when you're not, and its half-life is not that long, so they stimulate it for a while, They get all the pictures on the screen because they put a tracer in the blood, and they can see that vessels that can dilate and react and allow blood through, it's glowing up on the screen and we can see that. So we say, okay, that's an open vessel, and that's an open vessel. Here's one over here that's not open so much. So we can look at it that way. Now, quercetin, this is dipyridamole. This is an old drug. It's been around forever. And it opens coronary arteries. It dilates coronary arteries. So they used it for angina for years and years and years. Every now and again, you still see a patient on it. It's a good drug. You know, other drugs have come along, different generations, but it's a good drug. So it's also a platelet inhibitor, which helps. So it's going to dilate these vessels. They put a tracer, they give you this drug, it dilates those coronary arteries, and where the blood can go is lit up by the dye, and we can see it. It's not dye really, it's radioactive material. So not dye in the sense of like iodine dye. So adenosine is another one. And adenosine is an antiarrhythmic, and it's going to slow the heart rate down. So it's not increasing demand on the heart. It's not acting like your heart is exercising, but it's allowing it to slow down and vasodilate, which will allow blood through. And since we've put a tracer in, you can see where the blood is flowing, what vessel was allowed to give and let the blood through. So it gives them a very clear picture of what's narrowed and what's not. Okay. All right. So why don't we stop there, and I'll see you in an hour. Yeah. Okay.
Janie, can I ask one question?
Yeah.